we introduced الدكتورة بشرى منير من الجيل الصاعد والمتحفز للانطلاق في موضوع gender difference in cardiac diabetes patient and outcome.
Thank you. Okay, good afternoon. I will talk about gender difference in the cardio-diabetes outcome. People with diabetes have markedly increased cardiovascular risk, but the relative increase in cardiovascular risk is larger in the women. Women with diabetes more often have diffuse coronary disease, microvascular dysfunction, present with atypical symptoms, and carry higher post-myocardial infarction and long-term mortality compared with the men. The female has a special consideration for risk factors in associated with pregnancy complication, menopause, and endocrinal disease like polycystic ovary syndrome. Also, she has a common risk factors with men like genetic factors, insulin resistant, obesity, eating regimen, dyslipidemia, socioeconomic status, and exercise habit, hypertension, and diabetes mellitus. Modern cardiometabolic therapies like sodium glucose transport inhibitor, glucagon like peptide 1 receptor agonist give benefit for both sexes. But there are signals and subgroups analysis suggesting variation in magnitude of benefit of this medication and underrepresentation of women in many trials. So, sex-specific data remain limited. Major guidelines now emphasize aggressive cardiovascular risk assessment in all patients with diabetes and call for sex-aware care pathway. The female has a complication in sex and gender which lead to increased mortality, increased treatment delay, and increased emergency response times. For the epidemiology, the relative risk, several analyses and cohort studies show the women and diabetes have a higher relative risk of coronary heart disease, stroke, cardiac death, and all causes mortality compared with the men. For about 1.3 to 1.5 times higher relative risk, and some studies say for about 50% higher cardiovascular disease mortality in women than in men. For the post myocardial infarction and revascularization outcome, diabetic women have a higher in-hospital and long-term mortality after acute coronary syndrome and less frequent use of revascularization and guideline-directed secondary prevention. Also, for phenotype of heart failure, women with diabetes more commonly to present with HFrEF, while the men developed HFrEF diabetes increase the risk of heart failure for both sexes. Woman has special consideration also for her risk factor if she has any other disease like autoimmune disease, which increase the fold of her risk ischemic heart disease for 3 times. Gestational diabetes increased 4-fold higher of risk diabetes mellitus. Hypertension in pregnancy increased 3-folds. Early menopause increased for about 4.5 times. Depression is more prevalent to get twice time, and she has a traditional risk factor like diabetes, smoking, obesity, and inactivity if she has low physical activity. Diabetes more prevalent in women than men with heart failure. Also, reduction of the gender gap in heart failure outcomes, independent predictor of mortality in women, and less response to anti-diabetic drug in women. For the pathophysiology differences, she has a biological and vascular differences. The women more often have endothelial dysfunction, microvascular disease, and diffuse atherosclerosis. Also, the sex hormones like decreased estrogen after menopause modify the insulin sensitivity, lipids, inflammation, and vascular biology. For the risk factor patterns, diabetes amplify other cardiovascular factors like hypertension, obesity, dyslipidemia, and some of these confer greater incremental risk of women. Diagnostic and presentation issue: female patient present with atypical symptoms and less obvious ischemia lead to diagnostic delay in women, which can worsen the outcome of her management. Diabetes in female can cause myocardial infarction, coronary artery disease in form of atherosclerosis, endothelial dysfunction, and platelet aggregation, and decreased energy metabolism. In diabetic cardiomyopathy, the pathophysiology is fibrosis and energy metabolism. For additional health system and psychosocial, female patient has under prescription of evidence-based therapies, later presentation, greater psychological burden like depression, caregiver roles, and access barriers contribute to worse outcomes. Also, atherosclerosis tend to be more diffuse and microvascular disease, while in men present with focal epicardial lesion. Hormonal influence. Hormonal influence, estrogen deficiency after menopause accelerates insulin resistance and endothelial dysfunction. Also, female has a special consideration if she has cardio oncology, if she has any disease, the biological factor pharmacokinetic increase her risk. Also, the cardiotoxic medication like anthracycline, HER2 inhibitors, and radiotherapy increase the risk. In the adult congenital heart disease, heart defect also increase in the cumulative prevalence. Inherited cardiac condition, X-linked disorder associated milder phenotype with women leading to delay or misdiagnosis. In heart failure, we say the patient presents mostly in form of HFpEF. Also in coronary artery disease, less likely to be high diagnostic assessment, and the patient come with a typical presentation. For the cardiac rehabilitation patient, a female patient has a lack of adequate support due to the barriers in caregiving or socioeconomic. Also in non-invasive cardiovascular investigation, because of her anatomy, small heart, and the breast tissue may affect the diagnostic accuracy. Also, the clinical presentation, we say the atypical chest pain, dyspnea, and fatigue leading to underdiagnosis. The heart failure patient present with manifestation of her heart failure with preserved ejection fraction, and outcomes of after the major event, higher short and long-term mortality in women, worse outcomes after revascularization. In stroke, diabetic female have a disproportionately higher risk of ischemic stroke than men. Peripheral artery disease, women often present later with worse limb outcomes. So the female has a worse outcome for women in acute myocardial infarction in form of atypical presentation in treatment, biological bias, assessment bias, and the comorbidities which increase the risk. If we see the cardiovascular disease factors, we see some risk increase in the female, like obesity, glucose control, atherosclerotic, dyslipidemia, and inflammation. In the microvascular disease, the female has a low estimated GFR and dialysis mortality. Also, she has a relative risk factor for cardiovascular mortality, HIF, and stroke or congenital heart disease. In the treatment gaps, the underutilization of the medication, less likely to the woman has less likely to receive the therapies like statins, ACE inhibitors, sodium glucose transport inhibitors, glucagon like peptide 1 receptor agonist. Glycemic control also has a less aggressive glycemic targets, and in the clinical trial, women are underrepresented in cardiometabolic outcomes trial, leading to knowledge gaps. For the psychosocial and behavior factors, the female has a more prevalence of depression linked to worse cardiovascular outcomes. Also, for adherence of medication, women may face the socioeconomic barriers impacting adherence to medication and lifestyle changes. The treatment, what works and what are the six difference. Risk factor controls intensive control of blood pressure, LDL cholesterol, and smoking cessation and glycemic are foundational guidelines recommend to aggressive medication for the patients. For the sodium glucose transport inhibitor, strong evidence of heart failure and renal benefits across the sex, and the meta-analysis show benefit in both male and female. Some pooled analysis suggest the magnitude can differ from the female to the male. For the glucagon peptide 1 receptor agonist reduce the MACE and the mortality in many trials. So more research needed to precise the sex specific effect size. For the revascularization and secondary prevention, women with diabetes often receive less invasive management and fewer guideline therapies. Closing this gap is crucial. We need to measure the secondary prevention by the health service use, cardiac rehabilitation, guideline recommended care, and pharmacological treatment. The practice pointer treat the diabetes in women as a high-risk cardiovascular state, consider earlier and more aggressive cardiovascular risk stratification, lipids, blood pressure control, albuminuria, ECG, and ischemic testing when clinically indicated. Screen for atypical ischemic symptoms and microvascular disease, low threshold for functional testing or cardiology referral when symptoms are ambiguous. Prescribe evidence-based cardioprotective drugs regardless to the sex, ensure equitable use of statin, ACE inhibitor, sodium glucose transport inhibitor, glucagon like peptide 1 receptor agonist, and antiplatelet therapy when indicated. Track and close treatment gaps. Address social and psychosocial barriers for depression, adherence, and access, which disproportionate affect women and worsen outcome. Includes sex stratified data collection in registries and trial urine or use. This will improve the future evidence. Men not equal for the women in hypertension, obesity, and diabetes. Hypertension and obesity and diabetes in female not equal to the male. So we need research focused on randomized control trial, secondary randomized clinical trial analysis, and formal gender assessment. 2 evidence-based, 6 gender-specific clinical guidelines. As a summary, there is a difference in sex rate of type 2 diabetes mellitus and associated cardiovascular across the lifespan. The mechanism of type 2 diabetes onset in youth, اللي هو affected biological and environmental variables. The mechanism also impact on the type 2 diabetes and cardiovascular risk. 6 specific effect on pharmacotherapy for the management of diabetes and cardiovascular disease. In terms, there is a relative under treatment of women versus men, which may narrow at older age. Recent changes in clinical system have shown promotes to reducing despite in cardiovascular treatment. Women with diabetes carry a disproportionate higher relative cardiovascular risk compared to the men. They tend to present later with more atypical symptoms, microvascular disease, and worse outcome after acute coronary syndrome, heart failure, or stroke. Treatment gaps and underrepresentation in trial exacerbate disparities. Thank you.
شكرا جزيلا دكتورة بشرى، كانت معلومات قيمة. وطبعا الدكتورة بشرى هي الآن ماشية بأبحاث، مع أبحاث كثيرة. طبعا يعني أحب أن أقدم التهنئة للدكتور زايد وللشركة اليمنية المصرية، وعلى رأس الجميع الدكتور نبيل والدكتور حميد على هذه الفعالية. ما زالت القاعة مليانة وهم مستمتعين. واليمنية المصرية دائما وأزلا هي مشجعة وداعمة لكل النشاطات العلمية everywhere and anywhere يعني. فالشكر مقدم للجميع، وتأنها خاصة لأخونا الرائع الدكتور زايد. وإن شاء الله the next speaker